pleasure to be here today. I didn't travel as far as Min, but I'm from San Francisco, and I work at UCSF. And I'll be talking to you guys today about VR training to improve trauma care. So a little bit about me to give you guys some context. My name is Devika. I am the design manager, which is just a fancy way of saying I am a designer at a place called the Better Lab. And the Better Lab is an academic research center at UCSF, and what we focus on is using human-centered design to solve healthcare challenges. Very broad mission. We're challenge agnostic, but design specific. And we're really invested in using human-centered design, studying it, and trying to improve the care conditions in our context. To give a little context on that, the Better Lab is actually physically located at Zuckerberg San Francisco General Hospital, which is our large county hospital up in the Mission District of San Francisco. We are also the Level 1 Trauma Center, which is why this trauma training is what I'll be talking to you guys today. So first, I'm going to give a bit of an overview about VR education. So, VR in education has primarily been used as an immersive experience. And a lot of teachers, the study found that 83% of teachers think VR might help with improving learning outcomes. I wanted to give an example of a really great example of this, Google Expeditions. Their tagline is, "Go places a school bus can't." And what they do is that they have taken these amazing 360-degree still photos of different experiences all around the world. This one being bull sharks, I think in a coastal reef somewhere. And basically what the learning experience is like is that while you're immersed in this experience, you're looking around, the teacher might point out a specific shark to you, and then you're given some information about that experience, or about that learning point. Now in medicine, we have learned, there is a lot of, I guess, interest in using virtual reality to really amp up medical education. In surgery, there's a saying, see one, do one, teach one. Is anyone familiar with that methodology of you watch one first, then you try it, and then you teach it to your fellow residents. And a lot of that's focused on technical skills. So this image right here is of a really cool company called Oso VR. They actually have developed a VR simulator for orthopedic knee surgery, orthopedic surgery specifically for the knee. And it has some sense, I think they have integrated haptics and some really interesting things to really dive deep into this learning experience. There's a little bit going on in the soft skills arena, and it's also being used for patients in both education and therapy, which could be a whole presentation on it of itself, so I'm not going to talk about that. So what I really wanted to make a case about today is using virtual reality in medicine, especially in the case for trauma care. And the question that we always get is is this just the new gimmick? Is it the cool thing, we're just using VR to use VR? Well, we did some, we're human-centered designers, so we did some ethnography work, and we learned that this idea of 360 video, or VR, which I will be using interchangeably, is not just a fad. There are three main reasons we say that, and I'll dive deep into them as we go forward. But the first one is perspective taking. This is being able to understand the perspective of your fellow providers. There is also work in using virtual reality to understand the perspective of your patients as well. The second thing is this idea of an authentic experience. You can actually immerse yourself in a real-world scenario with real patients. And I'll show you how we're doing that at San Francisco General. And the third being is that you can take what we call taking reps, is practicing your skills over and over again, easily, and also in a safe environment. You're not harming patients, you're not straining a resource-constrained system. So now a little bit about trauma care. So the reason why we were even interested in trauma care in the first place is that our lab is on a mission to use the human-centered design process to improve trauma care at our hospital. So to give a little context, I work with a trauma surgeon, Dr. Amanda Salmon, who has spent her entire career taking care of critically ill patients. And her colleagues in emergency medicine and in anesthesia have found that, first, being a teaching hospital, second, having such a high volume of patients, we have around 90 high-level activations a month, which average to about 3 a day, which is quite a large amount of trauma resuscitations. That this was a really broken process in which our residents were really, really pissed off. They were just not happy with the way that they were receiving this education. They felt like it took them all of their training to learn how to do their ABCs, but no one taught them how to run a room. No one taught them how to manage the fact that there will be 20 people trying to resuscitate this patient with you. So we learned that no one really trains doctors to be managers or know what their other team members will do. And we learned that by conducting around 35 in-depth, in-context interviews with providers from all different services that are commonly in our trauma bay. And this is the kind of mindset I would like you guys to think about is imagine that every single time you're called in for a trauma resuscitation, you have an ad hoc team. It's a different group of people every single time. These are high-stress situations. Someone is dying. There is a lot of unknowns. A lot of times you have no idea what's going on, and there is an infinite number of decisions that need to be made in a very short period of time. So what we're doing, and in the process of doing, actually, is we're really trying to democratize trauma training. So what we're doing is we are filming 360 video and audio from 5 different perspectives in one of our trauma bays. We have a video kind of by the head of an anesthesiologist, which is usually the head of the bed. We have a camera on the right side of the bed, a camera on the left side of the bed, a camera in the back of the room where the charting nurse usually stands, and for some scenarios, we've also been able to put a camera kind of near where the head of the patient is. Depends on the trauma resuscitation, though. So I'm going to talk a little bit more about what that means, but I wanted to talk a little bit about the logistics of this because it is, I'm not saying this lightly, this has been like a year-long endeavor, and we're still in the middle of legal issues. So we're a research center, so we did an IRB. Nick this morning talked a little bit about the business associate agreement. We had to file one of those. It was an interesting kind of BAA because we were doing it between not only UCSF and the Department of Public Health, which is what San Francisco General Hospital is a part of, but also we have a third-party university that works with us, Ohio University. That's a HIPAA-compatible 360 video filming partner because we didn't have that capability at UCSF to film in 360 video. So we found someone else who could, being Ohio University. And then lastly, getting the hospital on board. We are filming real patients from real trauma resuscitations in a really big city where this could get a lot of attention. And having the support of all the chiefs of every service, along with the CEO of our hospital and the CMO of our hospital really was integral for making this project move forward. So we did, at the end of the day, this training is really about improving our trauma care during these really high stress situations and ensuring that our providers and our residents that are usually running these trauma resuscitations have the best kind of sense of how to manage all these competing priorities while they're in that position. So just to give you a little bit more sense of what this looks like, this is what one of our trauma resuscitation rooms in the hospital looks like. And we have, the gurney here. The 2 red boxes are where we have cameras hanging down from the ceiling. The green boxes are cameras that have been attached to equipment that already exists in the room. And the yellowish box is a camera that we secured to the underside of a gurney and kind of pops up around. And that's what it looks like in real life. Except actually we put white gaffing tape so it didn't look to the patients who came in that there's this triangular black thing that might fall down on them at any time with all these cameras to scare them when they were in our trauma bay. So this is actually what it looks like from the patient perspective we filmed a simulation of a trauma resuscitation to kind of test out this idea and this theory. So here you'll see that if you're kind of like looking up towards your toes as a patient, this is what it looks like to be a patient in that scenario. Now imagine being a resident or provider watching this and getting a feel for what that feels like. You see people are walking all around you. Nobody's said hi or said their name or anything. They're actively moving very quickly around you. They're throwing equipment over you. Sometimes in one case, we actually had equipment being dropped onto the patient, and our actor actually reacted a little bit because it hurt. Nobody really took that into account because of the high acuity of this situation. So I also wanted to talk a little bit about how we plan on researching this. We imagine that once we gain a repository of these videos, currently we have 3 consented videos. We get patient consent after the fact, obviously, and we were able to get 3 patients to consent to the around 4 900s that we have filmed so far. We aim to have residents watch this from the perspective of a provider that they're not familiar with. So if I was a surgery resident, I might watch it from the perspective of an anesthesiologist. And then we want them to provide feedback and what they assume were the perspectives and priorities of that provider. Then we want to have them watch that same scenario over again, but this time we're overlaying it with the actual anesthesiologist that was present during that trauma resuscitation, talking over it, overlaid with graphics to illustrate what they were really thinking about, what was really going on in their head while they were taking care of this patient. And then, sometime later, towards the end of this resident's rotation, they would watch a new VR scenario, and we would, be able to see if they were able to retain any of that information. So that concludes the end of the talk. I wanted to obviously give many thanks to the many people that made this happen. In particular, all of our providers and staff that participated in the filming, and of course, last but not least, the patients that we had the honor of taking care of and who consented. So thank you.